Welcome everybody to today's epidemic ethics seminar. Today's topic is really exciting, very important, and the panelists we have who will be introducing us to the discussion that will follow. It's a very qualified group of persons, and I'm really looking forward to hearing them present. But before we get started on today's topic, which is about indigenous communities, vulnerability, and the COVID-19 pandemic, I just want to say thank you to the Global Health Network for organizing this webinar, Catherine Littler from the WHO Ethics and Governance Unit for putting together this panel. Our panelists, and as you'll find out, they're from various parts of the world. So we have panelists from New Zealand who will be speaking to us from midnight, and others who are waking up in the morning in Brazil and Canada. But we would like to say thank you to them too for taking this time. And of course, thank you to everybody for joining this webinar. Today's topic is very important because COVID-19 has exposed many vulnerabilities. We've seen inequalities in the allocation of resources and healthcare based on the wealth of countries, based on gender, based on health conditions like HIV, and many other conditions of vulnerability that exist systematically and structurally within our societies. However, perhaps less attention has been paid to indigenous communities and how the COVID-19 pandemic has exposed systemic, historical, and structural injustices that these communities face. So today we have the opportunity to listen to a number of experts who will walk us through some of these challenges and how to address them. So the 4 questions of today's seminar are: how has the response to the COVID-19 pandemic affected indigenous communities? If the effects have not been proportionally fair and just, how can we avoid this for the future? And then, what has the discourse been like in terms of stigma and marginalization? And what role can indigenous communities actually play in contributing to the knowledge base that we have towards addressing pandemics? And this is a question of epistemic justice. Now, before I go on to introduce our panelists, I think there are some practical housekeeping bits of information and rules that I need to share with you. There is a live interpretation translation of this webinar in Portuguese and English. You will find the button, the language button at the bottom of the screen where you can choose the language in which you would like to follow the webinar. Secondly, the chat function is for you to introduce yourselves. Tell us where you're coming from, what you're doing. I mean, I've already seen that people are introducing themselves from all over the world. There are over 100 of us here, about 130 or so from various countries. And it's always interesting to see how these webinars manage to reach out to a global audience. And then the question and answer function is for posting your questions. We will then select these questions and try to share them with our panelists so that they can answer. And remember, you can actually vote for the questions so that in case there are many questions and we cannot address all of them, we will choose the ones that have received most votes, a sort of democratic system, let's call it that way. The session is live recorded and it will be streamed, live streamed on Facebook. And later on, it will be available on the Epidemic Ethics website so that you can actually watch and re-listen to, or actually share it with other people who might want to follow today's discussion, but were not able to participate. So without taking up further time, I would like to introduce our first presenters. They're going to present as a team, and they'll be speaking to us from from New Zealand. It's midnight their time, but thank you for making the time really to share your reflections with us. So we have Nora Parore, who is a community pharmacist, and she's also with the Maori Health Research. She's a fellow of the Maori Health Research Center, I think Hiringawaka, if I pronounced it right, at the University of Victoria, Wellington. And she's vice president of the Maori Pharmacists Association. And she'll be presenting together with Lindsay McDonald, who's done a lot of work, research. He's a senior lecturer at the Department of Political Science and International Relations at the University of Canterbury, Christchurch, New Zealand. He's an experienced researcher in the relations between the Crown and Maori communities, and a co-chair of the Aotearoa Research Ethics Trust. They will be talking to us about the experience of New Zealand, the Indigenous communities of New Zealand, with regard to the COVID-19 pandemic. So over to you, Nora and Lindsay.
Kia ora from Aotearoa, New Zealand. Thank you, Caesar. Can we have our slides, please? Thank you. That's great. If we could just get them blind. Thank you. Thank you very much. Manawa mai e te putanga o Matariki. Manawa mai e te ariki o te rangi. Manawa mai e te mātahi o te tau. Mai Aotearoa kia koutou katoa I te ao, manawa tia a Matariki. From Lindsay, Shannon, Niak and myself here in Aotearoa, New Zealand, to wherever you are in the world, we greet you all at a very significant time here in Aotearoa, New Zealand, as we welcome in the Maori New Year with the rising of the star cluster into the sky that Maori, the Indigenous peoples of Aotearoa, New Zealand, call Matariki. I'm pleased to start this presentation on Indigenous communities, and I'm reminded that as we prepared for our first wave of the Omicron variant in early February this year, our Māori health experts agreed that our COVID response left our Māori population uniquely vulnerable. Slide change, please. So Aotearoa, New Zealand is a diverse country, some would consider as having a bicultural history with an increasing multicultural demographic. Māori represent around 17% of our national population, and we are a young population with our median age around 25 to 27 years old, which is around 11 years younger than our national median age. What is unique to our Indigenous population is te tiriti o Waitangi. Considered our country's founding agreement written in both the Maori language and in English. Te tiriti o Waitangi guarantees health equity for Maori. It asserts the right of Maori to receive services and resources that reflect our needs as Maori and which result in equitable outcomes. However, there is a growing body of evidence that the systems governing, administering, legislating and funding primary healthcare services fail to meet the needs of Māori. This has been formally recognised, and Lindsay will speak to this on the next slide. But inequities in health outcomes exist between Māori and non-Māori and have been reported on extensively since the 19th century to present. And these inequities result from the unfair differential allocation and distribution of resources and power related to the determinants of health. We know Māori men die on average 8 years before non-Māori men, and Māori have significantly higher rates of disability, with 30% of young and working age Māori living with disabilities compared with 21% of young and working age people nationally. I'll now pass to Lindsay.
Kia ora koutou, everyone, and I'm really honoured to be here. We are representing the National Ethics Advisory Committee, which, as you can see, advises the Minister, and a most significant role is to give guidance on the ethical standards for the research on and service of health and disability services in New Zealand. So within that, we provided an pandemic ethics report, and we're working from that to some degree in this presentation. It needs to be said that we have a statutory health and disability ethics regime in New Zealand, which isn't a global human ethics regime. It just applies to health and disabilities. Can we have next slide, please? So COVID struck while an inquiry that's somewhat like the Truth and Reconciliation Commission in places like South Africa was looking at what health did, what happened to Māori health during colonisation. Just to give you a couple of other ideas about pandemics, the death rate following 1918 influenza pandemic was 7 times higher for Māori. And more recently, during the H1N1 influenza pandemic, disease rates were twice as high for Māori, while Māori were 3 times more likely to be hospitalised and 3 times more likely to die. The Crown was found by this Waitangi Tribunal in a report that came out not to have the capacity to deliver to rural and otherwise marginalised peoples, particularly Māori. Indeed, at one point early on, the government rejected advice from its own officials to adopt an age adjustment for Māori in the age-based vaccine rollout. Also, they tended to use mainstream medical health delivery for the vaccinations, which meant that those who have been impacted with colonisation and are suspicious for various reasons decided or had decided for them, if they were unable to get to those mainstream vaccination places, to not be vaccinated, which meant that throughout the rollout of the vaccinations, Māori were under-vaccinated. And I can come back to what that had caused in terms of stigmatisation later on. The Crown, in part, what we call the government, the Crown, didn't have enough data to actually work out how it could equitably roll out the vaccine to Māori. And combined with the decision to delay to younger Māori, there was created a time delay in vaccination for a group that's already marginalised. And this allowed disinformation and compounded the mistrust that already exists due to the lived memory of colonisation. It also noted, or has been noted, that we did need data, but it's been so used as a tool of colonisation that the public health officials found themselves in the spot where they didn't really want to release data on Māori vaccination rates in case it was used in racialistic ways, which in turn hampered the ability of Indigenous vaccine providers to get to those individuals who needed vaccinations. In many ways, it was one of the results you see of crises creating further marginalisation for those already colonised. Can we turn to the next slide, please? So the lack of attention to Māori health and the COVID response has accentuated calls for a more responsive health system. And we've had these before, but never quite so starkly have we had a commission of inquiry decide that the Crown made Māori lives less valuable through its decision. And so we now have a public sector health reform, which includes a Māori Health Authority created to deliver equitable health outcomes to the Māori. So out of the pandemic, in some ways, for the first time, we actually have a government wanting to achieve equitable health outcomes rather than just deliver equitable health opportunities. It may help that at the moment, the government has more senior Māori ministers than it has ever had. Influencing the reactions, or to answer the last question for this panel, there's a question about Māori health models that have begun to influence the health system. The most well known is the Whare Tapa Whā model of health by Mason Jury. And that's about the 4 pillars of Māori health coming out of what we call Mātauranga Māori or Māori knowledge. They are the spiritual, the family and social, the mental and emotional, and the physical. And Mason Jury and now the health system has come to discover of late, I suppose, that taking into account all of these improves Indigenous and non-Indigenous health outcomes. I suppose it might be quite like what some have called the biopsychosocial model in health. And that Te Whare Tapa Whā model, as I've said, comes out of Mātauranga Māori or Māori knowledge, in which Māori ways of seeing the world stretch scientific knowledge. The flip side of thinking about Māori knowledge and using it within the public health system, the government health system, has led to concerns made very concentrated in the epidemic to ensure that Māori data was held and owned by Māori, was used for Māori, and to be only used with Māori agreement. And this has come to be known as Indigenous data sovereignty, which has become a movement and a concern within a number of academics and practitioners, particularly in health, as the epidemic, the COVID epidemic, hoovered up all kinds of health data. But Mātauranga Māori or Māori knowledge is not something that can really be described in concrete abstract nouns, because it comes out of family knowledge and is very subjective, and its practice has led to a number of initiatives in which Nora has participated, and so she's best placed to take us through some of those. So I'm turning it over to you, Nora. Kia ora.
Kia ora, thank you, Lindsay. So I'll talk to the last point and the last 3 sub-points just to finish off our presentation. So Te Ao Māori values, or values from a Māori worldview, which is steeped in our knowledge from our ancestors. These 3 values have been taken directly from our NEAC ethical guidance for a pandemic document. And I'm going to just talk to 3 of the 6 principles and give an example of how I saw them in my clinical role as a pharmacist serving Indigenous populations. So tika. Tika refers to what is right and good for any particular situation. So how did this play out? A reminder that Māori make up about 17% of our population. And data at a time point in about December 2021 showed that Māori made up half of the country's infections with the Delta strain, 38% of hospital admissions for the variant, and 45% of the associated deaths. This is not right, nor good. And the Māori Health Pandemic Group, despite all the obstacles, were tasked with working on the front line, utilising their knowledge and relationships in the community to contribute to infection control and saving Indigenous lives. Because that is tika, that is the right thing to do, and that is good. The second point, kotahitanga, is the process of developing unity or togetherness, solidarity, and associated action as a collective. And we have many examples where Māori health providers stood up vaccination clinics for COVID, but they were accessed by many more non-Māori than Māori. It was a service by Māori for everyone. Māori know how to serve the collective, which is an excellent principle to have. And we have an example where Māori health providers from other geographical regions aided other regions to help address the issue of access to vaccinations as an example of collective action. And our final point is Manakitanga, which refers to caring for others, nurturing relationships and being careful in the way we treat others, and we seek to uphold the prestige and honour of all parties. And how this played out, I think here of one of my tribes, Ngāti Wai, in the northern part of Aotearoa, New Zealand, who were very specific and clear in their messaging and who delivered the message. So trusted medical professionals from the tribe. And the 3 messages were: get vaccinated, stay safe at home, and look after each other, or manaki I te whānau. Manaki means individual and collective care. Now, nationally, there was a distribution of hygiene care packs, and conversely, there were tensions of access to personal protective equipment from health professionals, our frontline workers. But the fact that we remained, or fact remains, of the importance of caring for our health, because this has been a marathon, not a sprint race, and we haven't fared well, as we all know, in past pandemics. Kia ora, that's the end of our presentation, Caesar.
Great. Thank you very much, Lindsay and Nora, for this presentation. You've given us many insights, not only about what happened with the pandemic, but also some of the concepts drawn from Maori culture that you've used in actually determining part of the response. The questions we have, I'll just share with you a question from Bayu Begeshao, and he's asking a question, or she's asking a question here about how do you categorize a native population in the case of Australia and New Zealand? For instance, in PhD studies among the Roma people, they tend to be considered more as new settlers or migrants rather than an indigenous population. So this is more of a theoretical question around the concept of being part of an indigenous people or an indigenous population. I don't know whether you'd like to comment on that briefly.
Nora, there's another question coming up about how we categorize Māori in COVID data systems, which I'll leave to you. I'd just say that as opposed to somewhere like America, where it's a case of law, in New Zealand, self-identification is the tendency, so that when you enter somewhere, someone asks, are you Māori? There are slight wrinkles with that. People have been tossed off the electoral roll claiming to be Māori when they're not, but that's very, very rare. It's basically self-identification.
Okay.
Yeah, Kia ora, I'll just add to that. There have been some research articles done to show that who is choosing when you present to hospital, perhaps the person behind taking the registration form is choosing whether you're Māori or not. But as Māori, I think we consider ourselves Māori when we have what's called whakapapa or genealogy, and we are all attached to land, to water, to a mountain, to a place, to a forest. And so as Māori, despite a whole lot of things happening with colonisation, a lot of people were, disconnected. I think the main answer would be whakapapa, Māori. And I'm apologising, my computer is forcing a restart on me. So I'm probably going to have to log out and log back in. I'm sorry, Caesar.
Yeah, no worries at all. Lindsay, so we'll just continue with the last questions before we move on to the next panelist. There's a question that came in at the beginning on post-COVID fatigue symptoms among the populations that you work with. And then another question on the identification for the data systems. And the final question that is about, the mistrust among marginalized communities. I don't know whether you would like to comment on these all these three questions, but briefly, so that we can then move on to the next panelist, please.
Nora, I'll leave that to you. I think about that first question about post-COVID symptoms. I'm not sure on clinical picture for Māori. Do you know if we've got any research yet?
I think because we are in Aotearoa, so down under, the rest of the world, a lot of what we've had, we're perhaps even 2 years behind Europe and what's happening up there. So we have had the benefit with everything, with the vaccinations, with the rollouts, with all of that to work from what's happening above. Long COVID seems to be coming in, but we don't have a lot of research. We've just had our first Omicron wave in February. We think that at the end of this winter, which is sort of next month, we're probably going to get our second wave. So we're still in the early stages of that. there. We do have our Maori pandemic group do run webinars for our different sorts of groups. So we might run them for schools, we might run them for our actual own health professionals to make sure that we're up to date with the medications and things that are coming out. But largely a lot of it, we're still copying what's happening up north of us.
Excellent. Well, these have been very good questions and answers. If you will still be with us, I know it's late for you in New Zealand, but at the end of the 3 presentations, we'll have more time to pick up on some of the questions. That is, if it's not too early in the morning by then for you. So I'd like to introduce the second panelist for our session today. She's from Brazil, so we're moving from New Zealand to Brazil. We have Josilea Jackson, who will be presenting from, I think, the state of, from Florianopolis in Brazil. That's where you're based. And she's a counselor for, a counselor for State Council of Indigenous People, a doctoral student in social anthropology at the Federal University of Santa Catarina, and was a UN consultant on women and professor of research and action in the intercultural degree program at the Federal University of Santa Catarina. So Josilea, over to you.
Bom dia. Good morning to you all. Thank you very much for the invitation. I highly appreciate this invitation to be part of this panel, and I'd like to thank the virtual seminar, Epidemiologic Ethics and Vulnerabilities of the Indigenous Peoples on COVID-19. I'd like to thank you, and I'd like to thank Professor Cesar for introducing me, and also I'd like to congratulate the other panelists on their presentations, and I'd like to say hi to the Brazilians that are following us. In Brazil, we are 305 indigenous people, different communities, and we have some isolated communities of indigenous peoples, the highest number in the world, and everything together, using our territories. We had a wide discussion about COVID-19, and we have a special secretariat for indigenous peoples, which is part of our health system, the SUS, S-U-S, which is the health system in Brazil that grants access coverage to all the population, and they do the primary care in communities, in indigenous communities, in indigenous territories. They are focused on those tribes, and I'm not talking about the indigenous population that do live in cities. I'm talking about the other tribes. And once the COVID-19 ecloded in Brazil, it reached the indigenous areas, indigenous tribes. There was a lack of information. The government did not inform us about that, and not even our special secretariat. And that prevented us from protecting ourselves on the territories. And the indigenous themselves, they promoted the follow-up, and they translated the documents in their native languages and created an indigenous frontline. The articulation of Brazilian indigenous peoples, which is the association known by the acronym API IB, they collectively decided to protect the tribes and to take information, to dissemination the information to amongst the indigenous population. We had our tribes directly affected by the pandemic. Over 27,000 indigenous were infected by the virus. And unfortunately, there was an action from the Brazilian government that translated in itself in a huge infection rate amongst the native population, because that was the result of the fake news dissemination carried out by the government itself. And unfortunately, that meant that the indigenous population was even more affected by the virus, by the pandemic. And besides that, in the indigenous communities, there was a shortage of tests. We could not carry out this wide testing that we should have carried out once somebody tested positive for COVID-19 within the community. So we had some indigenous professionals that unfortunately were on the front line of COVID, and they didn't have the PPI, the adequate one, equipment protection. And besides all that issues I've mentioned, we had to deal with formulation of new ways of tackling the pandemic with sanitary barriers. They were mobilized by the indigenous organizations themselves, and they carried out this protection. It was a way of facing the pandemic. And after uh, May 2020, we had this huge project from APIB, which is APIB, and we carried out wide, very huge debates, the very democratic ones, in which we put together experts from institutions, and they they put on the table unrestricted and comprehensive new ideas for us to face, to tackle the pandemic. And then we had we carried out a live from the indigenous, from the Brazilian indigenous people. So we carried out that live seminar, and that was also a way of telling the world about the huge violations, mining, illegal mining, and that got to the indigenous territories, and there was no one from the government to stand up against them. That's not, they didn't want to do that. So there are different tragedies that were piling up against the indigenous communities and the protection of the indigenous territories during the pandemic. So our most vulnerable groups were made even more vulnerable because of the pandemic, because there were no conditions whatsoever of tackling the disease. And that's why, unfortunately, we had to face so many losses of lives in our territories. And we have our older people, but also young indigenous people were dead because they died because the drugs they were using for the disease they were not effective. And the whole world kept saying and repeating that. But we knew that the medications, the drugs, were not the correct ones. But the Brazilian government, they created a parallel council, to go on forcing people to use such medicines, and they were taken into territory, into indigenous communities, into the tribes, and they didn't do us any good. It was just the other way around. So the use of the medication also showed from done by the government health system. It's a way of showing us that they were racist against us. So there were guidelines that were updated by the indigenous associations, and we have the numbers. 1,300 indigenous people were dead, and the infection rates were higher amongst the native tribes. And besides that, the Brazilian state was the main agent of the main focus of dissemination of COVID-19. Their health agents came from the outside, and they were not tested before joining the indigenous community. So the institutional racism is a fact, and that contributed to the increase of infections. And there was also this lack of primary attention for the indigenous people who lived or who live in urban centers. So the urban indigenous, they are not considered to be indigenous populations. They're considered to be uh, common ones. So we had to face all that, they were considered mixed race, instead being defined as indigenous just because they lived in urban centers in the city. So there were some research centers and institutions. They wanted us to mobilize our people to be vaccinated. So we carried out this huge campaign. It was that was called Vaccinate Your Relatives. So there was a call. We are calling our native populations to be vaccinated, while the government themselves uh, uh, insisted that vaccination was not a must-do thing, and the cure was not in the vaccination. So we had to deal with that, and we had to do some legal movements in the federal courts so that the indigenous people would be entitled to vaccination.
You have one more minute. Thanks.
Bem, para finalizar, então, os conhecimentos indígenas, né?
The indigenous knowledge, the traditional knowledge with our indigenous people, we carried out different debates, and to use this traditional knowledge to mobilize food and medicines, the ones that come from our traditional ancestors, to raise our immunity and to focus on collective care. And so that's why it was so important to be listening to our previous speakers, because we did use the same system to be focusing on the collective ideas, to be very careful about our food, so that we use the spiritual values as well, to have higher strength to face the pandemic, which is not over. And we are going to deal with lots of consequences of people who were previously infected, and they were able to face the virus and survive, but there are consequences to be faced and dealt with. So we haven't understood yet what are the long COVID issues, for instance. So I will be here, and I thank you for that.
Thank you very much, Josilea. That was an excellent presentation, and we can see the commonalities between what the indigenous people in New Zealand experience and what they experience in Brazil. And perhaps in Brazil, the great challenge was also the fact of not only the historical mistrust between government and the people, but also the fact that as you community leaders were trying to work with your communities, you also had to work against, or I mean, in the midst of a government machine that was also turning out news that did not really favor the people. So without leaving more time for questions so that we'll wrap up with all the questions at the end, I'd like to introduce our third speaker, Dr. Nicole Blackman. She's the Provincial Director of Indigenous Primary Healthcare, the Primary Healthcare Council in Toronto, Canada. And she'll be talking to us about the experience of the Indigenous communities in Canada. Dr. Nicole Blackman, over to you. Thank you.
Miigwech, thank you, Caesar. I'm just going to pull up my slides. Okay, can you see them?
Yes.
Yes, okay, great. Good morning, Miigwech. Well, good morning here in Canada. Miigwech, hello. Thank you for having me join today to talk about the impact of COVID-19 on the Indigenous population here in Canada. And just to set some context as to what comprises the Indigenous population. So Indigenous peoples in Canada are those that are First Nation, Inuit, and Métis. According to governmental statistics, the Indigenous population makes up about 6% of the general population. The national population, however, those numbers are thought to be grossly underestimated as the data collection tools tend to be government directed, and there is a lack of comfort or trust with self-identifying through those tools, and there's other factors. So it is thought that the population size is much greater. Similar to our colleagues from New Zealand, the population is a young population. We see that the percentage of those in the 0 to 21 age categories are significantly greater. And the Indigenous population is also the fastest growing population here in Canada. So I just wanted to set the stage in looking at the impact of previous pandemics on the Indigenous population, again, similar to my counterparts in New Zealand. And starting off with smallpox and the introduction of smallpox through the British Army, through blankets and so forth that were given to fur traders and Indigenous leaderships with the intent of combating the resistance that was happening with the land acquisition. And it ended at smallpox killed off approximately 90% of most communities and was very detrimental to the Indigenous population. There was also the 1918 Spanish flu, and had significant impacts on the Indigenous population. I think the rates of deaths was for every general non-Indigenous person, the rate of death was 6.2 per 1,000 people. But for the Indigenous population, it was 9 per 1,000 people in the province of Prince Edward Island, and up to 60% in those in Alberta. Then there was also the Spanish flu, H1N1, and significant challenges that arose with H1N1. So the Indigenous peoples accounted for just over 25% of those who became critically ill from H1N1. And unfortunately, H1N1 stealthily moved into Indigenous communities in Northern Canada. And due to data inequity, it really allowed the virus to spread to the remote communities with minimal detection. During H1N1, First Nation communities waited for weeks to receive appropriate PPE in order to help protect them and their communities, at which point the public health officials debated sending hand sanitizer to the communities for fear that they would drink the hand sanitizer for its alcohol content. And communities were actually sent body bags and toe tags rather than protective measures with H1N1. And then as well, even though the Indigenous communities were mostly impacted from H1N1, they were also excluded from receiving priority access with the vaccine rollout in fall of 2009. And so that kind of brings to COVID-19, when we look, and they were actually identified as a priority group for testing, assessment, and vaccination with the COVID-19. So with COVID-19, we did see systemic inequities, which placed Indigenous communities at greater risk right from the beginning. So in general, the Indigenous population had higher rates of the underlying health conditions, which were known to cause severe outcomes from COVID, such as diabetes, obesity, cardiovascular disease. As well, Indigenous people experience significant racism and discrimination on a regular basis when accessing mainstream services. And as a result, many Indigenous people were less likely to go to mainstream health services for testing, assessment, and then vaccination. So for many First Nation communities where they were able to contain COVID within their communities, it was a struggle for Indigenous leadership to be able to assert their rights to control who could and could not enter their territories. So as we saw lockdown restrictions that were beginning to lift, or as we saw people just being, tired of staying at home, tourists attempted to flock the Indigenous territories to go to their vacation spots, so even regardless if the communities were closed, or if they wanted to go and get their less expensive gas and cigarettes, they would attempt to go into the communities even though communities were closed. And in some cases, once they were told that they could not access the communities due to safety measures and the need to keep the community members safe, there was retaliation in which communities were told, if you can't come into our community, we can't come in, you can't come into ours. And that resulted in people not being able to access grocery stores and medical services and so forth from off reserve. So with the Indigenous experiences that we look at, specifically focusing on discrimination, as mentioned, the community response to First Nations lockdown were severe, and in many cases could be detrimental to health and social outcomes. There was also significant backlash with the Indigenous population being prioritized for vaccination. So when the provincial government here in Canada laid out the prioritization or the rollout for vaccines, Indigenous were a group that was identified as a priority group. So it was those that were living in long-term care homes, healthcare providers, and Indigenous groups. And unfortunately, it was well communicated why those that were 80 plus and in long-term care homes and those that worked in the healthcare system were prioritized for vaccination, but it was not communicated as to why the Indigenous group were. And as a result, that led to significant racism experienced towards the Indigenous populations, as many would say that they were just jumping the line and looking for a free ride. And as well, it also contributed to the mistrust from the Indigenous population, as they didn't understand why they were being prioritized and thought that it was to be guinea pigs and tested on just like they were done in residential schools. And then, so one of the solutions or, attempts to try and address the situation was to really start looking at Indigenous health and Indigenous hands. So here in Ontario,
Sorry, Dr. Nicole, you have about a minute and a half, please.
Okay, thank you. So here in Ontario, we have Indigenous primary healthcare organizations that are located across the province. They are they serve the Indigenous population, and so a lot of the care that was done, whether it was testing, assessment, vaccination, or COVID treatment, it was done through our primary care organizations, in which Indigenous peoples could access culturally safe and culturally appropriate care. We also developed a strategies to support Indigenous participation in Ontario's COVID response course. And this was really meant for those that were going to be leading COVID care and vaccination. So looking at ways to partner and collaborate with Indigenous populations and Indigenous organizations to deliver culturally safe care. We also developed and delivered a webinar for wise practices for those supporting COVID vaccination in order to help prevent some of the myths and misconceptions and prepare vaccinators. We also have Indigenous cultural safety training and Anishinaabe Minawaiwan, and we developed cultural safety for contact tracers and again the vaccinators. And we are in the midst of finalizing our bioethics curriculum, which was developed in the midst of COVID-19 and looks at different elements to care, including COVID response, but beyond just looking at healthcare. And that is it. Sorry for the rushed last couple of minutes. Miigwech.
Great. Thank you so much, Nicole. This was excellent. So as we're getting towards the conclusion of today's webinar, what I'd like to do is that we're now looking towards the future, and we've learned from the experience of the current pandemic. So trying to synthesize the questions that have arrived in the Q&A session, I'd like to pose a question so that each of you can try to answer these questions here. In terms of what we need to do for the future, so that some of the errors of the COVID-19 pandemic will not be repeated, especially with regard to Indigenous communities. One question here is about the fact that Indigenous communities live in rural communities, and these communities may be inaccessible, and therefore sometimes it's difficult to actually allocate resources to them. Or also it can be assumed that they are protected by the fact that they are isolated. So that's one question we received. And another question specifically dedicated to Brazil was to know whether we have data that can allow us to evaluate the impact of vaccines on the population, the Indigenous population, both urban and rural. And the question that keeps coming up is, how do we identify and define Indigenous in various contexts? Because it seems in some places they are called new settlers, in Europe, thinking about the Roma people. And I would like to see whether you could address these questions. So Nicole, can we start off with you? I think you're muted, Nicole.
Sorry, just trying to.
Yes. Yeah.
Sorry, which question in specific would you like me to respond to?
Well, the one about, rural areas and the fact that, they are considered, because of their isolation, perhaps they are considered low risk.
So in Canada, it's important to note too that the Indigenous population does live in northern parts of Canada, but also a significant portion lives in the urban settings. But for those in northern Canada where it is more fly-in, remote, and isolated, the Indigenous population in whole was identified as a priority group. And so we actually had an initiative that involved going into all of the communities and administering the vaccines at the very beginning of the rollout of vaccinations. And so the federal government partnered with the Indigenous community leaders across Canada to be able to go in and deliver vaccinations. And the good thing that was done as well is that all the vaccinators it was mandated that they received cultural competency training or cultural safety training prior to going into, so that they would have an understanding as to the hesitancy that may be there as a result of colonization and residential schools experiences and so forth.
Excellent. So we're now in the last 2 minutes. So what I'll just suggest is to all of the panelists in answering these questions, perhaps not specifically, but just tell us, what do you think we need to pay more attention to next time? So Can we start off with Josilea in 1 minute? Just tell us what needs to be done better with regard to Indigenous communities.
Bem, obrigada. Nós, povos indígenas, temos visto que é necessário, primeiro, um combate ao racismo estrutural que nós temos na sociedade, né, não indígena, um fortalecimento das nossas organizações indígenas e que se leve em consideração, principalmente, o que nós temos apontado como direções para a gente se proteger. Nós, organizações indígenas do Brasil, fomos quem principalmente combateu a COVID-19 nos territórios. Então, considerar o que os povos indígenas vêm produzindo enquanto informações, mas também pesquisas feitas por nós mesmos, eu acho que já é um grande avanço em uma outra oportunidade que a gente espera que não aconteça, porque, afinal de contas, a COVID-19 levou muitos dos nossos parentes e parentas indígenas. E no Brasil, nós tivemos a vacinação, só para completar, a vacinação principalmente das populações indígenas nos territórios demarcados. A luta para a vacinação dos indígenas em contexto urbano, né, ela se seguiu e nós precisamos aí, infelizmente, judicializar o governo brasileiro para conseguir efetivamente realizar a vacina com as populações urbanas. Obrigada.
Okay, thank you. The last word to either Lindsay or Nora, just half a second and then we'll go, half a minute and then we'll conclude, please.
I missed that. Was that me, Caesar?
Yes. Yes.
Yeah, sure. Very simply, in Aotearoa, New Zealand, we need to listen to Maori. We need to listen to our Maori health professionals. We need to listen to our Maori leaders, because we, as Maori, have the solutions for our people. We have the relationships with our people, and we value our genealogy and our connections to the land, the sea, and to the sky. Thank you.
Well, thank you very much. Unfortunately, the hour is up. We could have continued with more questions and more engagement on this interesting topic, but I think we've learned a lot. And actually, it's important to see how our panelists are all involved in activities that try to heal the systemic mistrust that exists between Indigenous communities, which have been, victims of, inequity for centuries. And in doing so, they are also contributing a lot to the health and welfare of the people. There is a lot to be done, and I think good work is already being done. Thank you very much. This webinar is being recorded and will be available online in the course of the week for you to be able to go back and watch it. Thank you very much, and enjoy your night or your morning or the rest of the day. Thank you very much. Goodbye.